Welcome back guys. Now in this video, let's discuss about the male sex hormones, okay, or the male reproductive hormones. Now let's begin our topic with the hypothalamus. Now we all know hypothalamus is going to produce a hormone called as GnRH. This GnRH is going to act on pituitary gland, so that the anterior pituitary is going to produce two important hormones. Okay, anterior pituitary is going to produce two important gonadotropins. What are they? FSH and LH. FSH, LH. These are the gonadotropins, right? So these gonadotropins, they are going to act on the gonads. Okay, gonadotropins, so they are going to act on gonads. So FSH is going to act on which cells in the gonads? Gonads are of course testes. So in testes there are actually two types of cells present. The two important types of cells which are present in the testes are called as the Leydig cells and Sertoli cells. So FSH is going to act on Sertoli cells and LH is going to act on Leydig cells. Okay, so FSH is going to act on Sertoli cells and LH is going to act on Leydig cells. So L stands for L. So remember something like that. LH is going to act on the Leydig cells. Say when FSH is acting on the Sertoli cells, the Sertoli cells helps in the process of spermatogenesis. Okay, helps in spermatogenesis. And Leydig cells are going to produce the testosterone. So it's the Leydig cells, it is the interstitial cells of Leydig. They are the ones which are going to produce the testosterone. Okay. Now the point which I want you to know is, see this testosterone, whatever is getting produced, okay, this testosterone is going to give the negative feedback. Okay, the testosterone is giving negative feedback to the pituitary gland and hypothalamus, which means whenever you are having sufficient amount of the testosterone is giving the negative feedback. Enough amount of testosterone is there. Or in a way you can also understand that testosterone is acting like a messenger that Leydig cells are getting stimulated by the LH. Okay, the Leydig cells are telling, the Leydig cells are communicating with the hypothalamus and anterior pituitary that I am receiving the LH, I am getting the LH. So testosterone is being produced and the testosterone is going to give the negative feedback to the pituitary gland and hypothalamus, right? Having said that, now let's discuss about the Leydig cell. In the Leydig cell, what exactly is happening? So in the Leydig cell, is the cholesterol. Okay, so cholesterol is like a raw material. Here is the raw material. So any hormone which is derived from the cholesterol is called as a steroid. So what I have said you, in the Leydig cells, it's the testosterone that's going to be synthesized. So testosterone is a steroid, definitely it's coming from the cholesterol. So what happens is this cholesterol molecule is going to convert into two forms of weaker androgens, two types of weaker androgens. See, these weaker androgens are called as DHEA. Okay, so dehydroepiandrosterone. Okay, dehydroepiandrosterone and androstenedione. Okay, androstenedione and dehydroepiandrosterone. Okay, not dehydroepiandrosterone sulfate, that's a totally different thing. This is dehydroepiandrosterone. Dehydroepiandrosterone sulfate is going to be produced in the adrenals. Now here in the Leydig cells, cholesterol is going to be converted into dehydroepiandrosterone and androstenedione. These are the weaker androgens. What are they? They are weaker androgens. Okay, they are the weaker androgens. Now what happens is, these weaker androgens are going to be converted. Okay, later they will be converted into testosterone. Okay, so they will be converted into testosterone. So this is how testosterone is going to be synthesized in the Leydig cells. Now what I want you to know is, see in the adrenal gland also, okay, in the adrenal gland, this cholesterol can be converted into these two molecules, dehydroepiandrosterone and androstenedione. See, till here the reaction can occur, but in the adrenal glands, the weaker androgens, this dehydroepiandrosterone and androstenedione, they are not going to be converted into testosterone. Till here they occurs in adrenal cortex. You know it, right? Adrenal cortex have zona glomerulosa, fasciculata and reticularis. So in the zona reticularis area, the cholesterol will be converted into the weaker androgens but not into the testosterone. Now, what happens to this testosterone? You already know, I have explained you in the previous video that this testosterone will be converted into more potent form, more potent androgen, that is DHT, that is dihydrotestosterone. So how this dihydrotestosterone is going to be getting formed? Okay, how you get this dihydrotestosterone is when testosterone is acted upon by an enzyme called as 5-alpha reductase. So this 5-alpha reductase is going to convert the testosterone into dihydrotestosterone, where in the peripheral tissues, not in the Leydig cells but in the peripheral tissues. Okay. So important points about the DHT. What are the important points? DHT is more potent. It have more affinity. Okay, more affinity for the androgen receptors. When compared to the testosterone, it have more affinity. And it is more stable, means more half-life is going to be there, more stable. Okay. So these are the important points about DHT. Now look here guys, it's the DHT, okay, it's thought to, okay, it is the main culprit in the development of, okay, DHT is thought to cause benign prostatic hyperplasia. Okay, that is BPH, benign prostatic hyperplasia. Okay. So DHT is the one which is going to cause the benign prostatic hyperplasia. From where this DHT is coming? DHT is coming from the testosterone. So testosterone is getting converted into DHT with the help of 5-alpha reductase. And it is the same DHT which is thought to cause the male pattern baldness. Male pattern baldness. Okay, where the frontal hairline is going to get receding, the frontal hairline is going to go back, along with there is a loss of hair from the vertex area, but the posterior hair, posterior and this lateral hair, which is not going to be lost. That's a classical male pattern baldness. So it's the dihydrotestosterone which is responsible for these two conditions, that is a prostate enlargement leading to the benign prostatic hyperplasia, which can lead to urinary retention, painful urination thing, and male pattern baldness. So why I am telling all these stories? Because there is a drug which can inhibit this 5-alpha reductase. Okay, there is a drug which can inhibit this 5-alpha reductase. So what is the name of the drug? The name of the drug is finasteride. So finasteride, utrasteride, these are the drugs. So finasteride is a 5-alpha reductase inhibitor which can be used in the treatment of prostatic hyperplasia as well as male pattern baldness. Okay. Next, what else I want you to know is, students, please understand, many students don't know this and they even get confused. Sir, testosterone can be converted into estrogens. Can be converted into estrogens, yes, possible. So in males, testosterone is getting converted into estrogens. Yes, of course, even in males, the testosterone is getting converted into estrogens to a certain degree with the help of an enzyme called as aromatase. Okay, where in the adipose tissue. This is called as a peripheral conversion. So testosterone is getting converted into estradiol. Okay, estradiol, which is the more potent form of estrogen. Why? The question is why? What is the function of this estradiol? See, even in males, estradiol is there, and this estradiol is the one which is going to be responsible for certain effects in the body. Yes, estrogens in the males are also going to bring out certain reactions or certain effects that we will discuss later. Okay. So important points what I want you to know for your exam is, it's the aromatase which is converting testosterone into estrogen. This process is called as a peripheral conversion which occurs in adipose tissue, and testosterone is also getting converted into dihydrotestosterone with the help of enzyme 5-alpha reductase, which can be inhibited by a drug called as finasteride. Okay, finasteride. So at the end of the day, what I want you to know is, see, in the Leydig cells, okay, in the Leydig cells. What's happening is you are having the testosterone, okay, there is formation of testosterone, and the testosterone is also getting converted, okay, the testosterone is getting converted into dihydrotestosterone, and it also getting converted, the same testosterone is getting converted in the periphery into estradiol, okay, estradiol. So in my body certain effects, okay, certain changes are brought by testosterone, and dihydrotestosterone is going to bring out different effects, and estradiol also going to bring some effects. So what are they? So when and where the testosterone is showing its effect, where the dihydrotestosterone is going to bring the changes in the body, and where is the role of estradiol in bringing out the changes in the body, that we will discuss now, okay. So first let's begin in the males. So at the I should say, so there are different effects of this testosterone. Testosterone is going to bring different, first let's begin with this, okay. Let's begin with this. Testosterone is going to bring effects in the body, in a male body, okay. When during puberty, or during adolescence, or during older age, or during infancy, when, see, it can bring changes during fetal life, during puberty, and during adult, okay. So in all these age groups testosterone can show its effects. Now let's begin with the fetal stage, okay. So during fetal stage, what this testosterone is doing in the body, see, males are having XY chromosomes, right, X and Y chromosomes. Y chromosome is having a gene called as SRY gene. Due to the presence of this SRY gene, it codes for testis determining factor. Testis determining factor. So due to this, males are going to have testis with two types of cells, that is the Leydig cells as well as Sertoli cells, okay. Now this testis is the one which is going to produce testosterone. Now what is the function of this testosterone? My question is, what is the function of this testosterone? Okay, males are having this testosterone, okay. What is the function of this testosterone? See, this testosterone is the one responsible for the development of internal and external genitalia. I will discuss in detail, but just here remember, the sex hormone, the testosterone, is responsible for the development of internal and external genitalia, okay. Now how that happens, we will discuss one by one. See, first of all you should know what are the male internal genitalia, internal reproductive organs, what are they? So internal genitalia. So the internal genitalia includes seminal vesicles. I used to remember like seed, okay. So seminal vesicles, epididymis, and vas deferens, okay, vas deferens. So I used to remember internal genitalia are seed, SEED, okay, vas deferens, okay, seed. For the development of this internal genitalia, okay, for the development of this internal genitalia, what do you require is testosterone. Requires testosterone. So testosterone is required for internal genitalia directly, okay. But what about the external genitalia? External genitalia, we are having the penis, okay, we are having the scrotum, prostate, all these things. So external genitalia. So external genitalia, they are derived, first of all, okay, you should know, sir, this seed is there, right, seminal vesicle, epididymis, vas deferens. These structures are derived from which area or which duct? Okay, testosterone is required. So testosterone is going to add, okay, is going to act on a structure called as mesonephric duct or Wolffian duct. Okay, derived from internal genitalia. It's derived from mesonephric duct or Wolffian duct. So, on this Wolffian duct, this testosterone is going to act and it's going to form seed, okay, internal genitalia. And external genitalia, they are derived from urogenital sinus. Now, for this, okay, for this you require dihydrotestosterone, more potent form of more potent form of androgen, that is a dihydrotestosterone. So, what are the structures which are coming under external genitalia? It's the penis, scrotum. Okay, so it's a uro, right? Something related to the urology thing, something related to the urinary thing. There is a bladder and prostate. For their development, you require dihydrotestosterone. So, at the end of the day, the point which I want you to know is, for the development of internal genitalia, you require testosterone. For the development of external genitalia, you require dihydrotestosterone. Okay, so this is these are some important points which you need to know in fetal stage. Testosterone on fetus. Now, let me give you more clarity. So, there is Y chromosome. There is Y chromosome in which SRY gene is there. That SRY gene is going to code for testis. Okay, this is going to be testis, and the testis have Leydig cells. Okay, Leydig cells. And what these Leydig cells are doing? Leydig cells are going to produce testosterone. Now, this testosterone, okay, it's going to act on the mesonephric ducts. Okay, when it's acting on the mesonephric ducts, you are going to have internal genitalia. Internal genitalia, you know it, it's a seed. Okay, seed. Okay, seminal vesicle, epididymis, as well as vas deferens, seed structures, you know it. But the testosterone will be later, with the help of 5-alpha reductase. 5-alpha reductase, it's going to be converted into dihydrotestosterone, more potent form. It is going to help in development of external genitalia. You know the structures: penis, okay, penis, scrotum, okay, urinary bladder, and prostate, you know it. Now, what else I want you to know here is, sir, this testis, it's not only having the Leydig cells, but it also contains some other cells which are called as Sertoli cells. I have already explained you. Sertoli cells. So, these Sertoli cells are going to produce what? They are going to produce something called as Mullerian inhibiting factor. Mullerian inhibiting factor or Mullerian inhibiting substance. And not only that, these Sertoli cells are forming blood testicular barrier, BTB, blood testicular barrier. Just like blood brain barrier, there is something called as a blood testicular barrier. Okay, Sertoli cells form that, and the Sertoli cells are also going to help in the process of spermatogenesis. They are like nurse cells. These Sertoli cells are like nursing cells. They help in the process of spermatogenesis. Done. Okay. Now, my question to you is, there is a condition called as 5-alpha reductase deficiency. Okay, let me write here 5-alpha reductase deficiency. Now, you should think what will happen in the baby who is having 5-alpha reductase deficiency. Imagine there is a person, time back, he is having 5-alpha reductase deficiency. So, which process is not going to occur? See, when 5-alpha reductase is deficient, there is no dihydrotestosterone. This dihydrotestosterone is not going to be produced. When dihydrotestosterone is not produced, so external genitalia is not going to be there. So, it's usually the point which I want you to know is, always the default genitalia is female genitalia. Okay, always the default genitalia is female genitalia. If there is testosterone, or I should say there is dihydrotestosterone, male genitalia is going to form. If there is no dihydrotestosterone, automatically female genitalia. Automatically by default female genitalia is going to form. So now there is this male, okay, there is this male where there is deficiency of dihydrotestosterone. So external genitalia automatically becomes female like. So by the time of birth, who knows, like this baby is a male baby but looking like a female baby. So this baby is considered as a female baby and raised as a female baby. But internally the baby is having testes, so it's actually a male but looking like a female, so raised as a female. Okay, this condition is called as 5-alpha reductase deficiency. It is autosomal recessive disorder. Autosomal recessive disorder. Okay, autosomal recessive disorder. Now, in this condition, what happens is there is no dihydrotestosterone. No dihydrotestosterone. Okay. So, what are the clinical features that are going to be seen? So, normal internal genitalia. Okay, normal internal genitalia, that is vas deferens epididymis. Okay, vas deferens epididymis and seminal vesicles are going to be normal. So, the normal external genitalia is going to be seen. But if you look at the vagina, okay, the baby is having now vagina, right? The vagina is going to be like a blind pouch. Okay, so vagina is having a blind pouch. It's going to end as a blind pouch. Now, what about the external genitalia? You know it already. So, external genitalia is female like. Okay, it is female like. So, these babies are going to be recognized as a females. Okay, or degree, for example, 5-alpha reductase deficiency. Complete deficiency means severe problems. For example, 5-alpha reductase is a little present, so a baby can have not a severe problem, but there can be hypospadias sometimes. Okay, female like or ambiguous genitalia or hypospadias can be seen. Okay, range of female genitalia. So, if complete 5-alpha reductase deficiency, complete female genitalia, half of, for example, 50% 5-alpha reductase deficiency is there means like, female looking or ambiguous genitalia or hypospadias can be seen. Okay, hypospadias can be seen. So, these are some important points which I want you to know. Next, what are the effects of testosterone? Okay, testosterone and dihydrotestosterone effect during fetal stage we have seen. During puberty, what's going to occur is the testosterone during puberty, high levels of testosterone is going to be there, that's going to increase the size of the penis. Okay, so during puberty increases size of scrotum, penis and testis. Okay, these sizes are going to get increased. And secondary sexual characters, because of this testosterone, axillary hair, pubic hair and hair on face, and chest. Okay, hair on face, chest, and deepening of the voice, deepening of voice, like male like voice or the low pitch voice. Okay, next, enlargement of the prostate, and seminal vesicles. All these things are going to be seen during puberty. During pubertal stages, these things are going to be seen. Apart from this, what I want you to know is the most important point I have said to you, that testosterone is going to be converted into the estrogens, and estrogen is going to show certain action. See, during puberty, there will be something called as a growth spurt. Okay, there will be something called as a growth spurt. Means rapid increase in the height. Okay, so this is because of estrogens. The testosterone is going to be converted into estrogens. Okay, and these estrogens are the ones responsible for growth spurt. Okay, for the growth spurt, these are responsible. Okay, estrogens are responsible. So testosterone is getting converted into the estrogens, and the estrogens are going to act on the bone, and they are the ones responsible for growth spurt. And not only that, these estrogens are responsible for the closure of epiphyseal plates. Okay, for the closure of epiphyseal plates, estrogens are responsible. Okay, next, during puberty, there will be acne. Okay, acne. So it's the testosterone receptors are present on the sebaceous glands. So let me write here, testosterone receptors on sebaceous gland. Testosterone receptors are present on the sebaceous glands. So more the testosterone, more stimulation of the sebaceous glands, more sebum can be seen, more sebum on the face can lead to acne. Okay, that sebum can actually block the ducts, and that can lead to acne. So what I want you to know is, more the testosterone, more chances of acne. That's the reason why in PCOS, polycystic ovarian syndrome, the female, you know it's in the polycystic ovarian syndrome, more amount of LH is going to be seen in the female, more LH, more testosterone is going to be seen in the females. So PCOS females are going to have acne. And females who are suffering with congenital adrenal hyperplasia, in congenital adrenal hyperplasia, okay, adrenal gland size is going to be more bigger. In this condition of congenital adrenal hyperplasia, the cortisol levels, aldosterone levels are going to be less, but the testosterone levels are going to be very much high. Okay, I should say the androgen levels are going to be very much high. Okay, testosterone is not going to be produced from the adrenal gland. It is a dihydroepiandrosterone and androstenedione. They will be elevated much more. So congenital adrenal hyperplasia patients can also have acne. Okay, so these are the changes which I want you to know in the puberty. So in the puberty, there is increase in the size of the scrotum, scrotal size increases, penis size increases, testis size increases. There will be increase in the size of the prostate, seminal vesicles, deepening of the voice, male-like voice, axillary hair, pubic hair, mustache, beard, and there can be hair on the chest. And during puberty, the estrogens, okay, testosterone is getting converted into estrogen with the help of aromatase in the adipose tissue, and that's the one responsible for the growth spurt, and that's also responsible for the closure of epiphyseal plate. And acne can be because of increased testosterone is going to stimulate the more and more sebum release, sebaceous gland secretions, and that can lead to acne. Done. Now during adults, okay, in adults, what this testosterone is doing, okay, in adults. See, in adults, it causes prostate growth. Okay, it causes prostate growth. So this prostate growth is the one which is responsible for benign prostatic hyperplasia. So what is the drug that you are going to use? See, this prostate growth, I have said you, it's because of dihydrotestosterone. So what you have to use? You have to use a drug which will inhibit the conversion of testosterone into dihydrotestosterone. And what is that enzyme? 5-alpha reductase. So who is going to inhibit this 5-alpha reductase? Finasteride. Okay, finasteride. Done. This is the one thing. So what I want you to know is, if you inhibit this enzyme finasteride, dihydrotestosterone is going to go down, so prostatic enlargement decreases, so that's going to be helpful in the treatment of benign prostatic hyperplasia. That's okay. But if you take testosterone, okay, for example, because of some reason you are taking the hormone replacement therapy, now you are taking the testosterone to increase the muscle mass. Okay, testosterone is a steroid, so it can be used to increase the muscle mass. Okay, so if you are taking testosterone, yes, there is a chance that more testosterone will be converted into more dihydrotestosterone, so that can lead to benign prostatic hyperplasia. So testosterone therapies, okay, testosterone treatments can increase the risk of benign prostatic hyperplasia. That's the one thing which I want you to know in adults. Okay, in adults, it can lead to benign prostatic hyperplasia. That's the one thing. Second thing is it can lead to male pattern baldness. Male pattern baldness. And third one, testosterone. For example, exogenous testosterone, if you are taking the testosterone from outside, it's going to show some abnormal things in the lipid profile. It decreases the HDL, the good cholesterol, and increases the LDL. Okay, so increase in the LDL and decrease in the HDL. So this kind of dyslipidemias can be seen. Next, so now let's discuss about Sertoli cells. We have discussed about the Leydig cells and testosterone. Now let's discuss about Sertoli cells. See, Sertoli cells, I have said you, they are the ones which are going to produce. Okay, they are the ones which are going to produce a hormone called as inhibin B. Inhibin B. See, this inhibin B is the one which gives the negative feedback to the FSH. Okay, for easy understanding purpose, those students who doesn't understand, is the FSH is going to act on the Sertoli cells. So Sertoli cells are the ones which are going to produce inhibin B. Okay, from where this FSH is coming? FSH is coming from the pituitary gland. Okay, gonadotropes which are present in the pituitary gland are going to produce FSH. So when you have enough amount of, or when we say that enough amount of the spermatogenesis is happening, everything is happening, the inhibin B is going to give the negative feedback to the pituitary gland, saying that yes, the Sertoli cells are receiving your FSH, Sertoli cells are functioning. So it's a communication back to the pituitary gland, everything is going well. Inhibin B is going to give the negative feedback. So what inhibin B is going to do is going to downregulate the FSH, everything is going properly, so you can decrease the FSH. Okay, so very important point is inhibin B is going to downregulate FSH. True. And you know the Sertoli cells, what are the functions of the Sertoli cells? Sertoli cells, they form the blood testicular barrier and they nourishes the spermatozoa. They are like nursing cells. They are nursing cells. They nourish spermatozoa. Okay, they nourish the spermatozoa. Now, what else I want you to know is, so the Sertoli cells not only produces inhibin B, but they also produce something called as androgen binding protein. So within the testis, the Sertoli cells are producing something called as androgen binding protein. So this androgen binding protein is going to go and bind with the androgens, okay, the testosterone, local testosterone, and they are going to increase the concentration, they are going to bind the testosterone, they are not letting the testosterone go into the circulation. So when compared to the periphery, in the local environment, the testosterone concentration is going to be so much high. Okay, so it's in the name itself, it's their androgen binding protein. So Sertoli cells are producing androgen binding protein, they are going to go and bind with the androgens, that's the testosterone. So testosterone levels are going to be super high in the testis, it's because of the androgen binding protein. Okay, almost 100 times more when compared to the periphery. The third important substance which is produced by the Sertoli cells are anti-Mullerian hormone or anti-Mullerian substance, Mullerian inhibiting hormone or Mullerian inhibiting substance. So what is the function of this Mullerian inhibiting substance is, see the point which I want you to know is, for example, imagine this is an embryo. See, in this fetus, okay, in this fetus, there are two types of ducts present. Okay, let me show here. This is one duct, the black color, which is the mesonephric duct or Wolffian duct. Okay, mesonephric duct or the Wolffian duct, which is going to form the male internal genitalia. But the same fetus is also going to have one more duct which is called as paramesonephric duct. Paramesonephric duct or Mullerian duct. Mullerian duct. So here my embryo is 46XY. Some students will have it out, sir, why in a male, this is male, right? 46XY is a male, definitely Y chromosome is there, it's absolutely male. So why in a male zygote or male embryo, why there is this paramesonephric duct? because the paramesonephric duct is the one which forms, which is going to form female internal genitalia. Is going to form the female internal genitalia, like the uterus, fallopian tubes, cervix, upper 2/3 of the vagina. All these are formed by the paramesonephric duct. Let me write here itself: uterus, fallopian tubes, cervix, and upper 2/3 of the vagina. All these are coming from the Mullerian duct. Mullerian duct or the paramesonephric duct. Now, each and every embryo have both the ducts. It's a male embryo as well as female embryo. Both the embryos have both these ducts. But in a male embryo, do you want the female internal reproductive organs by any chance? No, we don't want any female reproductive organs. So what happens is, look here, this is a male embryo. So it contains 46XY chromosome. This Y chromosome is the one having the SRY gene. This SRY gene is going to code for testis. The testis is the one which is having two types of cells. What are they? Leydig cells and Sertoli cells. So the Sertoli cells, what they are doing? The Sertoli cells are going to produce something called as Mullerian inhibiting hormone or Mullerian inhibiting substance. This Mullerian inhibiting substance, Leydig cells are going to produce the testosterone, that's okay. The testosterone is responsible for the testosterone. Later it will be converted into dihydrotestosterone. Dihydrotestosterone is responsible for development of male external genitalia. Testosterone is responsible for the development of male internal genitalia. So being a male, we don't want any female reproductive organs. So this Mullerian inhibiting hormone in males is going to inhibit, it's going to inhibit Mullerian ducts. So in male, there is no development of Mullerian ducts, so there is no uterus, fallopian tubes or cervix. Otherwise, they can be there. So this is a point which I want you to know. Next, see, now let's discuss about clinical correlation. The clinical correlation that I am going to discuss now is called as androgen insensitivity, syndrome, also called as testicular feminization syndrome. Testicular feminization syndrome. Now, you can ask me, what exactly is this testicular feminization syndrome, sir? What exactly is happening here? See, it is 46XY. It's a male embryo only, no doubt. It's a male embryo only. The problem is with the androgen receptor. Defect in androgen receptor. There is a defect in androgen receptor. So testosterone is there, but it is unable to stimulate. Testosterone is there, but it is unable to stimulate the testosterone receptors. So what happens? Now think. So the problem is going to be, let me put it this way. So look here, So testosterone is there, no doubt. And dihydrotestosterone is there, but it is unable to act. It's unable to show its effect. So what happens is, these things are not going to form. Male internal genitalia and male external genitalia are not going to form because the testosterone is non-functional, because the receptor mutation, receptor resistance is there. So definitely, automatically, in this condition, androgen insensitivity syndrome, the external genitalia becomes, the external genitalia becomes female-like. So it's a boy who is looking like a girl. It's a boy. Testosterone is there, but it is not functional. So absolutely, it's looking like a girl. So testis is also there, but testis is not descending down because scrotum is not there. So, undescended testis. Undescended testis. Okay. So, the testis might be just blocked in the inguinal canal. Okay, you can say in the question they can say there is some mass or some tumor like thing which is present in the inguinal region. Definitely it is going to be androgen insensitivity syndrome. The name itself it's there, androgen insensitivity. Androgens are not sensitive, they are not able to stimulate the receptors. So, undescended testes are there. See, the testes now they are present in the abdomen or inguinal canal. There is a chance that now actually they are supposed to present in the scrotum. Now they are exposed to higher temperatures in the body, so there is a chance that they can develop cancers. Okay, so they can develop gonadoblastoma, okay, dysgerminoma, or gonadoblastoma. So these are the cancers. These are the cancers that can be seen, okay, with this undescended testis. Now, what else I want you to know here in androgen insensitivity syndrome, it is absolutely a male looking like a female. Now, what happens at the time of puberty? See, usually by the age of 13 to 14 years, a female will come to her menarche, right? She is getting matured, we say, she is getting her first menses. But here the male is looking like a female. Okay, what about the menses? Do you think menses is going to be seen in this person with androgen insensitivity syndrome? No, definitely no. Why? Here in this condition, I want you to understand, see, it's the only problem with the testosterone. Only problem is the testosterone. Inside testis is there, inside the body, in the abdomen, testis is still there. So this testis, during embryo stage, testis contains Sertoli cells. These Sertoli cells are making anti-Mullerian hormone. This anti-Mullerian hormone is going to inhibit Mullerian ducts. Mullerian ducts are going to be inhibited. As the Mullerian ducts are inhibited, what about the uterus? No uterus, no cervix, no fallopian tubes, and no upper two-thirds of vagina. Upper two-thirds of vagina is also not there. So these patients are having external genitalia looking like absolutely like a female, but it's like a blind vagina. The vagina is going to be blind pouch-like. So by the age of puberty, okay, do you think puberty will occur? No. So these patients are going to come to the clinic with the problem of delayed puberty. Okay, no menses. Menses are not occurring. They are waiting 13 years, 14 years, 15 years. There is no menses. But what I want you to know is, in these females, testosterone is there. The testosterone will be converted into estrogens in the body. Okay, it's the testosterone which can be converted into the estrogens, not the estrogens which can be converted into the testosterone. No, testosterone can be converted into estrogens. So via the peripheral aromatization, testosterone is getting converted to the estrogens, and the estrogens are going to cause breast development. Okay, so during puberty, their problem is not the breast development. Yeah, they are going to have the breast development. They feel like they are females. They only think that they are not getting menses. Okay, they are not getting menses by time, but they don't know that they are male, and that breast development is because of the estrogens, and the estrogens are coming from the testosterones. Okay, and one more thing which you can see in these patients with testicular feminization syndrome is they do not have, when you do the physical examination, of course that blind vaginal pouch is going to be seen. Not only that, the key word is no axillary or pubic hair, because the testosterone is the one which is responsible for the secondary sexual characters. The secondary sexual characters like axillary hair and pubic hair are because of the testosterone. Now in these fellows, the axillary hair and pubic hair are going to be not present, or very scanty, very scanty. Okay, little to none is going to be present. So these are some important points which I want you to know regarding androgen insensitivity syndrome. Now after this, what else I want you to know is the temperature effects. How the temperature is going to show its effect on the spermatogenesis thing. Okay, temperature effects, let me write here. For the process of spermatogenesis, Okay, for the process of spermatogenesis, what do we require? High temperature or low temperature? What do you think? Say the testes are placed outside the body. They are not. Why? See, testes are very small things, right? There is a lot of abdominal space. Why don't we have the testes inside the body? Because our body temperature is not suitable for the spermatogenesis. So they are kept outside. Actually, it's kept 2 degrees lesser outside. Okay, that's more favorable temperature for the process of spermatogenesis. So spermatogenesis requires low temperatures. Okay, low temperature. That's the one point which I want you to know. And Sertoli cells are very much sensitive to temperature. Okay, Sertoli cells are very much sensitive to temperature. But what about the Leydig cells? So Leydig cells are not sensitive, or I should say less sensitive to temperature. Okay, so if someone asks you in higher temperature, if you increase the temperature, okay, if you increase the temperature, what's going to go down? What's going to go down? Spermatogenesis. Definitely spermatogenesis goes down. Okay, spermatogenesis is going to go down. And what about the inhibin B levels? Inhibin B levels also goes down because the Sertoli cells are very much sensitive to the temperature. If you increase the temperature, Sertoli cells are not going to function. If the Sertoli cells are not going to function, inhibin B levels are going to go down. If inhibin B is going down means inhibin B gives the negative feedback to the FSH. If inhibin B is going down, what happened to the FSH? FSH goes up, FSH levels increases. Okay, FSH level increases. But what about the testosterone? Testosterone levels are not going to be so much affected with the temperature because the interstitial cells of Leydig they are not sensitive. They are not sensitive to the temperature. So the testosterone production is usually going to be maintained even at the higher temperatures. So even at high temperatures, testosterone levels are maintained. Okay, they are going to be maintained even at the higher temperatures. So these are some important points which I want you to know for your exam. Now in the next video, I will be discussing about the female reproductive hormones. Okay, here the main points which I want you to know is what are the different types of testosterone. See, testosterone, dihydrotestosterone, epiandrosterone, and dihydroepiandrosterone, sulfate, androstenedione. See, these are the different types. There are the 4 different types of androgens which I want you to know. And what are the functions of the androgens? Androgens like testosterone responsible for the internal genitalia development. The dihydrotestosterone which is responsible for the external genitalia development, and the Mullerian inhibiting hormone from the Sertoli cells are responsible for the involution of the Mullerian ducts. Okay, and Sertoli cells are the ones which are responsible for the development of the spermatogenesis, nursing cells. And inhibin B is coming from the Sertoli cells. Inhibin B is giving the negative feedback to the FSH, so the FSH levels will go down. So all these are the important points which I wanted to know. And don't forget about the benign prostatic hyperplasia and the drug which is finasteride, which can be used for also treatment of male pattern baldness. And androgen insensitivity syndrome, where a male is looking like a female with normal breast development, even the breast size is going to be bigger. Okay, because lots and lots of testosterone is there in the body which is not functional. The testosterone is getting converted into estrogens. All the testosterone is getting converted into estrogen. So much testosterone is getting converted into so much estrogens, so that estrogens are going to cause the breast development. So she is going to have almost Tanner size 4 breast. Okay, Tanner size 4 breast is going to be seen somewhere around like 20s. Okay, now this is a female who is 12 years old or 13 years old who is going to have a bigger breast, which is something unusual for her age. So bigger breasts are going to be seen, but there is no menarche, and the pubic and axillary hairs are not going to be seen. Okay, blind vaginal pouch is going to be seen without any internal female reproductive organs. What is the problem? The undescended testes, which may be just present in the inguinal canal, there is a risk of dysgerminoma or gonadoblastoma. Okay, so these are the important points which I want you to know regarding the male reproductive hormones. Hope the video is helpful. Thank you. See you in the next video.